Hello, myself Dr. Sheena. So today we'll be dealing with the topic the working length determination. So this is one of the most important step after we do access cavity preparation and before going into the cleaning and shaping of the root canal. This is a very important step that has to be taken. So what is working length? Working length can be defined as the distance from the coronal reference point to a point at which the canal preparation and cleaning and shaping along with obturation should terminate. So that is called as the working length. So what is a reference point? In the case of an anterior tooth, the reference point is always the incisal edge, while in the case of a posterior teeth, it is any of the cusp tip that is taken as the reference point. So what is the importance of doing a working length determination? That is because we have a particular point called as a reference point till which the cleaning and shaping as well as the obturation has to be terminated. So what happens if the cleaning and shaping of the moves beyond this working length? It causes irritation on the periapical area. Often the healing is affected. Thus the prognosis of the treatment might be actually affected. So it is very important to properly know the working length. So we need to know what is a reference point properly. The methods of determining the working length include the early conventional methods and the advanced methods. What are the conventional methods? Normally, Inkel's formula is actually used. In Inkel's method, it's not formula, Inkel's method is used for actually calculating or determining the working length. Next is there is a formula that was given by Grossman, that is Grossman's formula. Bain's method is there, and Cutler have given the radiographic apex and all, and that is a person who actually gave the Cutler's method of working length determination. Digital tactile sense means through our hand itself we can actually feel the apical foramen. There will be a particular point after which the file actually shows resistance. So that is digital tactile sense. Apical periodontal sensitivity is also a particular point patient actually shows pain. So that is apical periodontal sensitivity when we actually move our file into the root canal. Next is paper point method, radiographic grid method, and endometric probe method. Advanced method mainly comes the electronic apex locator that is commonly used nowadays, and the various radiographic methods also come under the advanced method. So explaining each. First is the normal radiographic method or the Inkel's method we carry out. So there are certain terms that you need to know in this. First is like we will be taking the preoperative radiograph of the tooth to be treated. Just think that this is the preoperative radiograph, and from that, with the help of a ruler, we will calculate the length of the tooth. So calculate the length of the tooth. From that, we will reduce 1 mm. Just think that we got about 24 mm. We reduced 1 mm. You can see in this image that there is a reduction of actually 1 mm. So there is 23 mm here. You can see 23 mm. And we will transfer this 23 mm to the file, and this file is inserted into the root canal. So why 1 mm is actually removed? That 1 mm is actually called as the safety allowance. Sometimes our radiograph might not be proper. There might be image distortion taking place or magnification. So in order to compensate for these two, what we do is like we actually reduce the 1 mm, that is actually called as the safety allowance. And as I said, we will be first calculating from the preoperative radiograph. We'll be reducing 1 mm called as a tentative working length, and to file we'll be actually taking that, putting it into the root canal, and we'll take the radiograph. Okay, once we take radiograph, check whether there is any difference between the instrument end and the radiographic apex. If there is any change, add or subtract accordingly. So that is and then the confirmatory radiograph has to be taken. So here the term safety allowance come, that is 1 mm, that is actually to prevent the distortion as well as magnification. That was Inkel's radiographic method. Grossman's method is actually a formula method, and it actually calculate the length of the tooth, actual length of the tooth. It is very easy. Here comes the tooth in one side, here comes the instrument. So actual actual length of the tooth to the radiographic length of the tooth is equal to actual length of the instrument divided by the radiographic length of the instrument. This is the actual length of the tooth. So here we can actually we can actually guide in having whatever is required for us. So memorize this formula just by a code: tooth on one side and instrument on the other side, actual length by the radiographic length. Next is Wayne's method. Wayne's method is also a radiographic method, very important. What he recommended is like there where should be the obturation be stopped, where should be the cleaning and shaping be stopped. That is based on the condition of the periapex and bone. See, when there is no bone or root resorption, that is the periapical area is okay, as in the case of this image. See, we need to actually reduce it by 1 mm. That's it. If it is actually normal radiograph where the periapex is okay, there is no bone loss, resorption, just end the cleaning and shaping 1 mm short of the apex. Next, if there is bone resorption, think that there is actually bone resorption on the outer area, we need to short it by 1.5 mm of the apex. If it has bone on the outer side as well as the root resorption here there is bone resorption as well as root resorption, we have to reduce 2 mm. So simple. No resorption if it is having proper apex, short of 1 mm. If it is having the bone resorption, shorted by 1.5 from the apex. If it is actually bone as well as root resorption, 2 mm has to be reduced. Next is Cutler. Cutler's method is like he is a person who studied the root apex, and he told that there is something called as the minor apical diameter, or the narrowest portion of the tooth where the obturation has to be terminated, and it should not extend beyond this minor apical foramen. So that is the concept of Cutler. So simply what he did was that he just from radiograph he did analysis where the major foramen is, where the minor foramen is. He calculated the length of the root, and he found out that that was the length how he calculated, where he entered it in the minor constriction. This is a minor constriction. There he extended. Now how he calculated the width is like, if the canal was narrow, we should clean to 10 to 15 size of the file. If it is an average size canal, we have to clean and shape to 20 to 25. And if it is a very wide canal, we have to clean and shape till 30 to 35 of a file. Next, what is periodontal sensitivity? This is based on patient's response. It is not related to a radiographic method, nothing. What we have to do is like, we will be actually passing the instrument into the canal, and when it comes in contact with the apical constriction or the apical few millimeter from there, the patient will start eliciting pain and he will give a response. Based on that response, we will actually come to the conclusion that that is a apical constriction, or the area where the obturation as well as the cleaning and shaping should be stopped. Next is the paper point method. This is one of the most easiest and reliable method in an open apex. See, when there is an open apex case where there is no constriction areas, what we does is like, we'll apply a paper point into the root canal, and when it comes in contact with actually the bloody area or the moisture prone area, we can actually see the blood get actually absorbed to the paper. Till that, actually we have to stop the cleaning and shaping, and also the working length has to be determined. Next, very important method, till this was the conventional method. Next, most important is actually the electronic apex locator. It is an advanced method. You can see there is an instrument which consists of a lip clip and also a file holder is there. So the other name of apex locator is apical foramen locator. This is an electronic device that is used to estimate the canal length. And the apex locator consists of various parts. First of all, it consists of a lip clip. So this lip clip is actually put on the patient's cheeks or lips. Second, to complete the circuit, it also consists of a lip holder. You can see this holder. This hold on to the file onto which the file which is kept on the tooth. So it is like, this is our tooth, and there is actually the instrument over here. The patient's one end, it is connected to the lip the other end is actually connected to the file that is actually placed in the tooth. So this actually completes the circuit, right? So apex locator typically consists of the lip clip. This is the lip clip. This is the file holder, the instrument itself, and the code that is actually connecting the parts. And it displays the, it indicates, it actually shows the path through which the file actually reaches the apex, right? So history is very important when we study on electronic apex locator. Mainly two important names, Suzuki and Sunanda. So there are various generation of apex locator based on the mechanism or the methodology by which it was developed. So Cluster was the first person who actually introduced an electronic method to actually locate the apical phenomenon. Custer. It is Custer. Next is Suzuki was a person who actually discovered the electrical resistance between the periodontal ligament and oral mucosa. It means that how this like apex locator shows that the reading. So normally we have the periodontium. You can see this image. There is the periodontium is here, and we are connecting lip on one side, right? So the mucosa have a resistance. Periodontal ligament is also a tissue or a mucosa. So when we actually insert it in the canal, when the file reaches the apical foramen and reaches the mucosa or the periodontal ligament, the resistance of the lips get matched with the resistance of the periapical space, that is 6.k ohm. There is a time where the beeping sound actually we hear from the apex locator. Hope you understood. We have two parts, lip clip and the tooth to which it is attached. When we like enter the file into the root canal, the point at which the resistance of cheeks and the periodontal ligament matches at 6.5 ohm, it produced the sound. So that concept was given by Suzuki et al. And Sunanda was the first who developed a machine to actually measure the tooth length. And Kobayashi et al. Reported the ratio method. So that is the four important names that you have to memorize when you deal with the electronic apex locator. So as you can see in this image, this is a very important image. You can see this is the lips or the cheeks to which the clip is actually placed, and files are actually placed within the canal. And what happens is, like, when we insert into the canal, you can see when we actually insert into the canal, when the file actually reaches the apex, what happens is, like, when the file actually reaches the apex, the resistance of 6.5 ohm and the lip also have 6.5 ohm, they matches. At that time, it produce a beeping sound showing that it have reached the apex and touching the periodontal space, right? So talking about the various generations of apex locator. First is generation is the resistance type. So resistance type means, so how I used to memorize the various generations is like, first generation is R for resistance. Second generation is I for impedance. Third generation is for frequency. RIF. I used to memorize like RIF. First is resistance. So first generation usually actually calculate based on the resistance. As I said earlier, the electrical resistance between the mucous membrane and periodontium is matched as 6.5 ohm. So it is the direct current being used, and very important thing, it uses a dry field. And some of the example, just for your knowledge, it is Apex Finder, Digipex and Neosono. Second generation, as the code suggests, it is RIF, that is impedance. Impedance is actually based on the concept that our canal is actually hollow. That is, root canal is hollow. So what happens is, like, there is a sharp decrease at the cemento-dentinal junction which can be measured electrically. So impedance is actually calculated as we actually move to the cemento-dentinal junction. As we move to the lower part of the cemento-dentinal junction, the value from higher point, it actually reaches and it comes down. There is a sharp decrease which actually suggests that it is the cemento-dentinal junction. And the tooth exhibit increase in electrical impedance across the walls of the root canal, which is greater apically than coronally. At the cemento-enamel junction, the impedance drops dramatically. So what does it mean is like, so this is actually the coronal portion and this is the apical portion. So in the apical portion it is actually greater. This is like consider it as 100, and the coronal portion think it is like 50. So what happens is like as we move down, it keeps on increasing, and at a particular point there is sudden drop. Think that it reaches the 60, 70, 75. That's like a sudden drop of 30. So that means that that is the cemento-dentinal junction or the constriction area which comes. Hope you understood, right? And some of the example, so first it was DC current used. Here it is alternating current being used. Endocrator is and endometer is two examples of the second generation apex locator. So the first was based on resistance, second was based on impedance. First was based on matching of 6.5 ohm on equal side. Here it is based on actually the transparent denti. What happens is like from the apical area, from the coronal area to the apical area shows the maximum number, but in between that there is a sudden drop. That shows that we have reached the cemento-dentinal junction. Third generation RIF is the code we used. F for frequency. So again, the frequency is being actually calculated. Nothing much to explain. Explanation is not needed. Just memorize that it is actually the frequency type. The frequency difference between the periodontium and the hollow canal is being calculated. Fourth generation, just know the name. It is a combination of resistance and capacitance. That is the first one, resistance, and a newer term, capacitance. It is actually separately calculated rather than the impedance form. And there are certain combinations nowadays. The apex locator is having a combination with the endodontic handpiece. Endodontic handpiece are those to which the files are attached, and we'll be doing a cleaning and shaping. So both cleaning and shaping and apex locator is there. Very important examples. Try Auto ZX. Auto start stop mechanism, auto torque, auto apical reversal method. Every autos are there. Just memorize like that. When autos are there, you just think that it consists of not only the apex locator but also the endodontic handpiece. So this is another question that was asked when I actually gone through the previous question paper. This was the question that was asked actually. Working length of the root canal is, so it should be exactly at the apex, so 1 to 2 mm apical to the apex, 1 to 2 mm short of the apex, 0.5 to 1 mm short of the radiographic apex. Of course, the term radiographic apex is there. That is what we actually often observe. So it should be 0.5 to 1 mm short of the radiographic apex. So this is a very important topic, working length determination. You need to know the range from which the working length is determined, the various radiographic as well as the conventional methods, and what are the various electrical apex locator methods, and just memorize that RIF, resistance, impedance, and frequency. And as I said earlier, radiographs are nowadays being used for apex location. That is like subtraction radiography is there, where we'll be comparing the early and last images together, and we'll be actually subtracting the unwanted image and find out working length. The most commonly used working length method is of course apex locator, and those persons name who are introduced Custer, Suzuki, Sunanda, etc. has to be memorized in this. Hope you understood this topic. Let's see in the next topic. Thank you.